All right. Hello, everybody. Welcome to Grand Rounds on this Monday, October 3rd. We're delighted to have folks joining us, even as we know that the floors are busy. Appreciate you making time for us. And we're particularly appreciative to have back with us Dr. Benjamin Hirsh, who is a preventive cardiologist, the director of preventive cardiology over at Northwell, and the co-founder and co-director of the Lipid Center and the co-director of the Lipid Apheresis Center, one of only two lipid apheresis centers in Manhattan. He got his BA and MD at Northwestern and Emory, came to New York where he did his internal medicine residency at Columbia Presbyterian and his fellowship uptown here at Mount Sinai. And we are delighted to have him with us today talking about cholesterol and cardiometabolic disease. Dr. Hirsh.
Well, thanks, Dr. Weissman, and the faculty, and especially the residents for having me today.
Oh, and I forgot to mention, sorry to cut you off already, but I think today's your birthday. So
I was trying to keep that a secret.
Thank you for joining us on your birthday, spending your birthday with us.
It's the one thing I wanted to do was give grand rounds.
Glad we could make your wish come true.
All right. Well, thank you very much, and thanks again to the faculty for having me today. So today I'm going to be speaking on a topic that is becoming increasingly relevant to everyone's practice, and that's our treatment of cholesterol, obesity, and insulin resistance. So no current disclosures. The goals of my talk to review the benefits of new and emerging therapies for the treatment of cardiovascular risk and dyslipidemia, and review not just the outcomes of treating to very low LDL cholesterol, but also the lessons learned from doing so, which could hopefully alleviate many perceived concerns. And then to review novel therapies for the treatment of obesity and insulin resistance, which honestly can be more impactful than a focus only on lowering of LDL. So moving on to a broad overview of newer therapies used in the treatment of cardiovascular risk. So before we kind of dive into newer therapies, it's important to remember what is often forgotten. There are really numerous factors that contribute to plaque formation, and cholesterol is really only one of the many factors. That said, it is still a significant risk factor, and it's treatable now more so than ever. So over the last 30 years, there have been numerous statin-based trials demonstrating the benefit of lowering LDL levels in both primary and secondary prevention trials. The findings of the cholesterol treatment trialists demonstrated, as you can see on the left, a log linear relationship between reduction LDL concentration and reduction coronary heart disease events. With the TNT trial, and then ultimately trials looking at the addition of ezetimibe and PCSK9 inhibitors, including Improve It, Fourier, and Odyssey trials, we are now at a time when we have kind of answered the question as to whether adding certain cholesterol lowering therapies that further reduce LDL also reduce cardiovascular risk for patients who are on maximally tolerated statins. But now we need some guidance as to how to best approach the use of the numerous medications beyond statins that are now available to reduce cardiovascular risk events in our routine practice. So beyond ezetimibe and PCSK9 inhibitors, other medications have demonstrated benefits in targeting different lipoproteins, such as EPA-only fish oils, SGLT2 inhibitors and GLP-1 receptor agonists targeting obesity, diabetes, and insulin resistance. There's also evidence for agents that are much less commonly utilized, but still demonstrate benefits, such as canakinumab for inflammation, I always have trouble saying that, extended dual antiplatelet therapy, and low-dose rivaroxaban. Again, very uncommonly utilized, but still with benefits. So now we have a number of therapies to reduce atherosclerotic risk. The arrows in this figure point to medications beyond statins for which their use reduces cardiovascular disease risk. We will be focusing on the ones in blue, but also discuss some of the newer and emerging therapies such as inclisiran, which is an every 6-month injectable PCSK9 inhibitor. We'll discuss some of the lipoprotein A inhibitors, and then even angiopoietin TL3 inhibitors for refractory FH. And we're now moving on to the safety of very low LDL cholesterol and the future direction of PCSK9 inhibitors. Oops. So first, I look back at PCSK9's history. So in 1985, the LDL receptor was discovered, and statin therapies became our primary medications in the treatment of cholesterol. In 2003, PCSK9 loss of function mutations were discovered in individuals who had very low LDL cholesterols and were also found to have lower cardiovascular disease prevalence. From there, they developed antibodies to reduce PCSK9 expression. In 2009, the antibodies evolocumab and alirocumab, or Repatha and Praluent, were developed, and trials were initiated, and then therapies were approved in 2017. In 2015, the siRNA, or single interferon RNA, PCSK9 inhibitors were developed, and trials again were initiated, and now actually recently approved in 2021, even before outcomes trials have actually yielded results. So now in 2022, they're actually looking at even newer technologies such as yearly vaccines against PCSK9 and even base editing, which has shown permanent inactivation in primates. And with the PCSK9 inhibitors came the insight into the efficacy and safety of lowering LDL cholesterol to remarkably low levels never previously thought possible. So these are the 4A and Odyssey trials for evolocumab and alirocumab. And to be brief, because I'm sure you're all familiar with this, each of these trials demonstrated that when a PCSK9 inhibitor, either Repatha or Praluent, was added to a maximally tolerated statin in patients with atherosclerotic cardiovascular disease, outcomes improved alongside dramatic reduction in LDL to median levels in the range of 30 to 40 milligrams per deciliter. And with these low LDL cholesterol levels, many became concerned, particularly with regard to safety. So how low can we safely lower LDL cholesterol? We know that cholesterol is an essential component of all cell membranes, and it's critical to not only the maintenance of normal cellular function, but also synthesizing steroid hormones. So a reasonable concern would be that with profound LDL reduction, aren't we diminishing this cholesterol stores and possibly compromising steroid synthesis and cholesterol end products as well as cellular function? So in order to answer this, we have to consider whether LDL is actually essential to supply cholesterol to peripheral tissues. In other words, are cells dependent on cholesterol derived from LDL? And the answer to that question is actually, well, it doesn't appear to be so. Cholesterol synthesis is really a highly regulated process, and it is predominantly synthesized, as you can see on the left, de novo, or it's acquired from HDL. And contrary to the basic assumption that HDL brings cholesterol from the arterial wall and delivers it to the liver, it actually delivers a significant amount to peripheral tissues. So almost all of the cells acquired cholesterol is from HDL, and actually LDL is really an insignificant source of cholesterol for steroid synthesis. On the right is one example you can see that shows that demonstrate that's the source of cholesterol acquisition in both adrenal and gonadal organs is predominantly de novo from HDL. Of course, it is still reasonable to remain cautious. So in the PCSK9 inhibitor trials, the FDA required testing of many hormones, as well as cortisol and ACTH, compared to placebo. So despite reducing LDL to very low levels, there were similar levels of cortisol and ACTH after 52 weeks of treatment. So how about going even lower into ultra low levels of LDL cholesterol, less than 10 milligrams per deciliter? So in a pre-specified secondary analysis of the 4A trial, you can see that even with ultra low LDL levels, less than 10, on the left side, outcomes continue to demonstrate a lower event rate. And on the right side, you can see that there really was no difference in adverse events compared to patients with an LDL of greater than 100. And probably the greatest concern raised by clinicians was whether or not there are cognitive effects of either LDL lowering or the use of PCSK9 antibodies. So why has the data demonstrated no adverse neurocognitive effects? Well, as in peripheral tissues, the central nervous system predominantly synthesizes cholesterol de novo or acquires it from HDL. And more importantly, atherogenic lipoproteins like LDL cannot even cross the blood-brain barrier. So it's this fundamental physiology that actually explains why we are not seeing the neurocognitive effects. And to further address these concerns, I did the Ebbinghaus study, which was published alongside the Fourier trial. And here they examined the neurocognitive outcomes in 2,000 of the Fourier patients at baseline, 6 months, yearly, and 5 years out. And these were not just basic mini mental status exams, but rather kind of rigorous scoring of spatial working memory, processing, reaction time, and memory recall. And there really was no difference at all in the scores, even among patients with very low LDL cholesterol, including those with LDLs less than 25. So this leads kind of to an overriding important question of, should we be lowering LDL to very low levels in everyone? This slide is from the Lancet and is a pooling of over 1 million patients in 27 statin secondary prevention trials. And the purpose is to prove a point on applying risk to decision-making. The major point that I want to drive home here is that the greatest absolute risk reduction is seen in the patients with the highest baseline cardiovascular risk. So to be more specific, if you look on the graph, on the y-axis, which is on the kind of the right part of that graph, those with the highest or the greatest vascular risk, greater than 30%, had the most number of events avoided at the same absolute drop in LDL concentration. So basically, in other words, lowering to very low levels of LDL may be worth a lot, but really the greatest benefit is in the highest risk patients. Another important principle is to highlight the importance of duration of therapies. We all have to realize that most patients, about 50% of them, discontinue therapy after 1 year, even in clinical trials. So although these studies are often short, the benefit does accrue over time. This is a graph of the cardiovascular benefits seen at varying treatment duration slopes for the Fourier, Spiral, and then some different statin trials. So similar to the concept of area under the curve, the benefit of therapy is equal to the efficacy of the therapy times the duration of therapy. In other words, so on a similar statin, or sorry, a similar dose of, for example, Repatha, a proportional drop in cholesterol levels leads to sustained reduction in vascular events, but the longer the patient remains on therapy. So how about emerging therapies and the future of PCSK9 inhibitors? So as shown on the left, we are now utilizing agents against PCSK9 expression in a number of different ways. We're currently obviously using antibody to the PCSK9 protein, but what is also approved is inclisiran, which I use for specific patients. So as you can see on the right, it allows for an every 6-month dosing schedule that's actually provided at the office visit, which is kind of a new model that health systems are adopting for this new medication. Inclisiran is a small interfering RNA agent that binds the mRNA and directs the catabolism of this mRNA before it can encode the gene that makes the PCSK9 protein. And we're even taking this further into base editing for a number of diseases with established genetic bases. So using this CRISPR-Cas9 technology, which is being used for a lot of genetic diseases, has really opened the possibility for permanent alterations in genes, including that which encodes the PCSK9 protein. So basically, this technology allows for precise alteration in genomic DNA, altering just one base rather than the prior technologies that really depended on DNA repair processes. So with these prior technologies, there are more off-target genetic alterations. It's Seth Kathiresan's team at Harvard has used the CRISPR-Cas9 technology to permanently block PCSK9 gene expression in non-human primates, actually showing a decrease in plasma PCSK9 and a concordant decrease of about 60% in LDL cholesterol over the last year of observation. So obviously the clinical application of gene editing will require considerable regulatory and ethical surveillance, but honestly, the power of these evolving technologies is coming, and such that they're so powerful that genomic intervention is going to be inevitable. The last point here is that before we move well beyond statins, we need to remember that patients are not even taking statins who can actually tolerate statins. So I was fortunate enough to be part of this group where we reviewed data from both randomized clinical trials and clinical trial registries. We showed that many providers are reluctant to start statins or up-titrate statins. So even if patients came in on simvastatin 20 with an ACS event, they often leave on simvastatin 20 as opposed to a 12 or 80 or Crestor 40. It's kind of improved since we wrote this up, but the point being that there's a lot of clinical inertia with statins, and patients are not even taking statins. So a much bigger challenge is making sure that patients are actually taking our first-line medications to begin with. So now moving on to other therapies that reduce other than LDL cholesterol lowering therapies, such as LPA reducing therapies and the benefit of other medications such as fish oils. So this trial was really pivotal. The recent REDUCE IT trial is considered to be really a landmark trial establishing the role of specific fish oils to not only moderately reduce triglyceride levels, but substantially reduce cardiovascular risk. The study enrolled or randomized greater than 8,000 patients with moderately elevated triglycerides between 135 and 500 on statin treatment who had either established cardiovascular disease or were at high risk for cardiovascular disease, which basically just meant diabetes plus one additional risk factor. They received either a highly purified EPA-only based fish oil compound, icosapent ethyl, or placebo mineral oil. After 5 years of follow-up, there was a 4.8% reduction in composite cardiovascular events, which translated to a 25% relative risk reduction in the treatment arm. So notably, the STRENGTH trial, which used Levasa, which is an EPA plus DHA combination fish oil, did not demonstrate this benefit. So the point I really want to make here is we now have strong evidence that we can lower cardiovascular risk with the addition of Vascepa, but not with Levasa, and that's a big misconception of providers. And so why the benefit of Vascepa only? It's really the EPA component. So on the left is a slide that demonstrates the level of circulating EPA correlated with reduction in cardiovascular outcomes. And on the right is kind of a summary slide of the positive fish oil trials to date. And they really have only, and this is for, by the way, just cardiovascular disease, not necessarily other effects of fish oil, such as neurological outcomes, which I can't really speak to. But for cardiovascular disease on the right, there have now been only 2 positive fish oil trials, and they have both been EPA only. So the first was the JELIS trial in 2002, out of Japan, which looked at 2 grams of EPA only fish oil. And now, 20 years later, the Reduce-It trial demonstrated the same benefits at a greater magnitude with 4 grams of EPA only fish oil. So while fish oil could come in all forms, we only have evidence that EPA only purified fish oil is really able to reduce cardiovascular risk on top of statin therapy. Lipoprotein A is the next major target of therapy, and something I've actually been very involved in and interested in clinically and in research as well. So it is a risk factor for heart disease and stroke, independent of all other risk factors, including LDL cholesterol. So to understand its structure, just a very brief review. All bad cholesterol has apolipoprotein B attached to its surface. Lipoprotein A is an LDL-like lipoprotein, but with ApoA attached to the ApoB moiety. So it really should be measured in nanomoles per liter, but either greater than 75 nanomoles per liter or greater than 50 milligrams per deciliter is actually considered elevated. As shown on the right, it acts like LDL cholesterol in that it can be proatherogenic via oxidation and inflammation, but it's also prothrombotic, particularly at very high levels, thought to be due to its structural similarity and therefore competition with plasminogen. No significant drugs other than PCSK9 inhibitors, which only lowered about 20% on average, or apheresis are available for treatment yet. At Northwell, I'm actually the principal site investigator for a phase 3 Novartis study assessing the effect of an antisense inhibitor versus placebo in patients with atherosclerotic cardiovascular disease and elevated lipoprotein A. The drug lowers LPA by preventing its production. So we've actually been lucky to be the second highest enrolling site in the US. We still have a ways to go as a study expected to read out in 2025, but this study will ultimately raise awareness for people to check LPA, since we will actually be able to hopefully treat it. Amgen has also developed olezarsen, a similar type medication that's kind of moving into phase 3 at this point, with a small molecule against LPA as well. So shifting gears to a newer therapy for patients with refractory FH, there's now an angiopoietin TL3 inhibitor, evinacumab, which lowers cholesterol levels by about 50% through an LDL receptor independent mechanism. So basically, under normal conditions, and sorry to get into some science here, but lipoprotein lipase and endothelial lipase work to metabolize and remodel the VLDL particle, which then becomes LDL, which is primarily cleared by the LDL receptor in the liver. In the setting of impaired LDL receptor function, such as that which we see in familial hypercholesterolemia, LDL in the bloodstream accumulates. Evinacumab works by inhibiting angiopoietin TL3, which increases lipoprotein lipase and endothelial lipase activity to the point that VLDL remnants can't be converted to LDL, and so they get cleared by the liver, and there's less circulating LDL. So I've actually used evinacumab on 3 patients. It only costs about $400,000 a year, but so each one of those actually was a case report. And on the right, it's actually being published in JACC this month. We described the implementation timeline of therapies for a patient with homozygous FH and ischemic cardiomyopathy. We use rosuvastatin, bempedoic acid, ezetimibe, and despite these therapies, the patient's LDL remained in the high 200s. We then used evinacumab, which dropped her LDL to about 100, but ultimately apheresis was still required. Another patient of mine, we were able to lower the LDL with evinacumab to our goal without having her have to go through apheresis therapy. So here are some of the emerging lipid therapies targeting PCSK9 and angiopoietin TL3. We already described antibodies to PCSK9, single interferon RNA, and gene editing, but also in development are vaccines and oral PCSK9 inhibitors, which still have a long way to go. Similar to PCSK9 inhibitors, the angiopoietin TL3 inhibitors also have these siRNA vaccines and gene editing in their future as well. So really shifting gears now to therapies which target obesity and insulin resistance, which has obviously become a major epidemic. So with the rising prevalence of obesity and insulin resistance, we now have a rising pool of triglycerides and triglyceride-rich lipoproteins that continue to increase in our population. And they're really becoming very important targets of therapy. So elevated triglyceride-rich lipoproteins contribute to what I think is becoming a huge issue, which is fatty liver disease and cardiovascular disease. And they actually cross the arterial wall just as LDL does. In this publication, we actually described how, unlike LDL cholesterol, these triglyceride-rich lipoproteins don't require oxidation to form crystals and plaque, and that they also contribute to inflammation, endothelial dysfunction, and coagulation. So there's really a growing need to address these lipoproteins. So what medications do we have to address these issues and others? So we've already mentioned the angiopoietin TL3 inhibitors, but obviously that's fairly cost prohibitive. But how about more of the essential and kind of dynamic medications, such as the SGLT2 inhibitors and the GLP-1 receptor agonists? So when you think about SGLT2 inhibitors, you should be thinking about how these medications reduce long-term risks, not just A1C. So similar to our core medications that we use to reduce risk in cardiovascular disease and kidney disease, these new medications have been found to be effective for three primary purposes. One, to reduce atherosclerotic cardiovascular disease risk, to improve heart failure, and to reduce the progression of kidney disease. I'm sure that you guys have been inundated with information on SGLT2 inhibitors, so I'll make this brief, starting with a very quick data review for SGLT2 inhibitors. The main point I want to emphasize on this slide is to summarize the benefits of reducing of these medications in reducing atherosclerotic cardiovascular disease or major adverse cardiovascular events. So with the SGLT2 inhibitor empagliflozin or Jardiance, it significantly reduced both cardiovascular events and demonstrated a mortality benefit. In the CANVAS and the CREDENCE trials with canagliflozin and the DAPA-HF trial with dapagliflozin, there were also reductions in major adverse cardiovascular events. So now on to the GLP-1 receptor agonists. 4 of the GLP-1 receptor agonist medications were found to be effective in reducing cardiovascular events, 3 of which currently are commercially available, including liraglutide, semaglutide, and dulaglutide. In the LEADER trial with liraglutide, it also reduced all-cause mortality. So this is where it gets a little bit interesting. Understanding how GLP-1 receptor agonists work is really kind of an interesting and important concept. So basically, in essence, remember that for insulin-resistant patients, they have higher levels of baseline circulating insulin. So what GLP-1 receptor agonists do is they suppress appetite and slow gastric emptying. They also reduce hepatic gluconeogenesis. So essentially what they are doing is they're calorie restricting patients and lowering baseline glucose, which overall reduces their circulating insulin. Additionally, as incretins, they further improve the insulin response to a food bolus, which basically drives substantial positive downstream benefits, making them highly effective. And with respect to the FDA indications for GLP-1 receptor agonists, currently they are predominantly used for reduction of cardiovascular events, specifically amongst patients with type 2 diabetes who are at risk for or with established cardiovascular events. Also, for the first time since 2014, the FDA has approved another weight loss medication, semaglutide. So obesity is the most prevalent chronic disease worldwide, affecting approximately 650 million adults. And with the excess adiposity comes numerous complications, including type 2 diabetes, fatty liver disease, and cardiovascular disease. Historically, the treatment of obesity focused almost exclusively on lifestyle-based approaches. But now there's evidence that obese patients are limited in weight loss by counter-regulatory mechanisms. And they really serve as a barrier to not only weight maintenance, but reducing weight. So this has kind of led to a realization that obesity is a complex, multi-component metabolic disease of energy homeostasis involving central and peripheral mechanisms. So basically, once obesity is present, these mechanisms render it very difficult to return to a lower weight. So that's why now there's actually several guidelines that recommend treatment with GLP-1 receptor agonists for people who have obesity or who have overweight and have weight-related complications. So on the right, you can see that the efficacy of semaglutide with regard to weight changes over time. You can also notice how weight loss continues even over a year out. So it's important, again, the concept of duration for patients to remain on these therapies and to see the benefits over time. And the latest development of this class of medications is tirzepatide. Tirzepatide is a GLP-1 receptor agonist and a glucose-dependent, hopefully I can get this right, insulinotropic polypeptide, or GIP. So as discussed before, with GLP-1 receptor agonists, again, we see that same caloric deficit, increased insulin sensitivity, but it's just augmented with the GLP-1 receptor agonist and the GIP. The GIP component is thought to act centrally to potentiate a GLP-1 induced reduction in caloric in food intake rather. It also acts peripherally again to regulate energy balance and to affect signaling in the brain and adipose tissue. Importantly, with these agents, we are seeing greater than 20% reductions in weight. This is on par with sleeve gastrectomies. So it's really a major advance in using medications where otherwise patients would have to turn to surgeries only. And what's notable here is, just like with semaglutide, with tirzepatide, the weight loss again continues over time, even to 1.5 years out. So duration of therapy, again, is a theme that continues to emerge with different therapies. This is just to illustrate that in patients with type 2 diabetes, a single molecule combining the GLP-1 receptor agonist and GIP has a greater effect on glucose levels and weight control than selective GLP-1 receptor agonists alone. And then on the left here, you can see the current FDA indications, doses, side effects, and average weight loss for these medications. So some important questions remain unanswered, and that is, how do we prevent, so if we put patients on these medications, how do we prevent the immediate return to weight gain and insulin resistance once we stop therapy? So that's something that really does need to be explored. Otherwise, patients will have return of weight gain and will have return of insulin resistance once you stop the medications. So there's really a lot to be explored here, including whether we can prolong that physiologic calorie deficit and increase sensitivity accompanying their use. And also, the use of these medications allows for collaboration across internal medicine subspecialties. So we formed a group to increase the use of SGLT2 inhibitors and GLP-1 receptor agonists across the Northwell Health system. This is our team, and really a lot of practitioners aren't comfortable prescribing these medications. So we created this team to educate faculty and trainees and provide kind of clinical cheat sheets and guidance. We also developed a Microsoft Teams pharmacy consult where you could just type in a question via Microsoft Teams to a pharmacist who could answer a question about side effects versus or insurance coverage, et cetera, to get that answered quickly. And we'll be tracking the impact on provider use, risk factors, and clinical outcomes. And really, the major point here is also that the ownership of these medications by other specialties is becoming necessary because endocrinology is inundated with diabetic patients. My patients, as I was telling Dr. Weissman before, are now waiting 9 months after a diagnosis of diabetes to get in to see an endocrinologist. So there's really a dearth of endocrinologists, and we, outside of using insulin, have to start taking ownership of these patients. So shifting gears to what's probably the most serious issue, which is the importance of lifestyle changes. So what is the reason we're all here? So it is because we used to kind of actively grow food and chase prey, but now we're completely content staying at home ordering a Big Mac. And it is actually the reason that we are having to address obesity and diabetes. So you may probably hear Eve Merrill laughing in the audience, and it's not because I'm actually funny. It's because when we went to college together, she would be eating salads and I would always order burgers. So now, as a preventive cardiologist, 20 years later, I can finally admit to Eve that she was right. So in all seriousness, we're consuming highly processed foods and beverages, and lots of sugars, saturated trans fats, and this makes us feel terrible throughout the day. It's very harmful to our health, and we just simply turn to medicines and procedures. And yes, just as I outlined, there are lots of great medicines coming out, but it's all because of the fact that we're not living a healthy lifestyle, and it's really harmful to our minds, our bodies, our longevity. And this is an important point, often glossed over, even in the secondary prevention cholesterol guidelines. A healthy lifestyle is the first step. So people really aren't taking that first step in order to improve their risk of cardiovascular disease. And studies have shown that when high-risk primary prevention patients are randomized to receive a Mediterranean diet or continue eating as usual, major adverse cardiovascular events are avoided. In the Lyon Heart Study for patients who had a prior MI in the preceding 6 months, cardiovascular events and overall mortality was reduced when provided with a Mediterranean diet. And these outcomes improved regardless of lipid lowering, regardless of their blood pressure, and regardless of weight loss. And it only took 3 years for the Lyon Heart Study to demonstrate that nutrition can improve survival. That's really powerful. And most of our medications take much longer for prevention studies. Obviously, in heart failure studies, it's different. So let's briefly touch on the beneficial diets. The vegetarian and plant-based diets, the Mediterranean diets, the DASH diets, they all reduce diabetes, hypertension, hyperlipidemia, and mortality. So while we don't know the exact components that are the most beneficial of each, and how much of the less favorable components of the diet should be accepted, we got to focus on the big picture, and that 70% of these diets are identical. So we should be emphasizing basic components of fruits, vegetables, whole grains, legumes, fish, while really minimizing processed food, beverages that are, that have lots of sugar, and snacks that are in bags like potato chips, pretzels, etc., as kind of a filler throughout the day. So I imagine that many of you have heard this line from patients who have trouble losing weight, and that is, but doctor, I really do not eat that much. And oftentimes people are oblivious to the fact that there's a mismatch between caloric density and quantity. And you could have a bite of a cheesecake and it could be an equivalent in calories to a stomach full of vegetables that would provide more benefit and still fill you up then still fill you up. And then not to forget, of course, exercise and cardiac rehabilitation. So basically here, the authors looked at about 16,000 patients with stable coronary heart disease, examined the benefits between exercise and mortality. And they found, as shown on the left, that there was a graded decrease in mortality with increased physical activity, with the highest benefit seen in the first part of that curve. So that is to say that the greatest benefit was seen amongst those who went from being sedentary to being physically active. With increasing volumes of activity, patients had additional benefit, but really the absolute or the incremental decrease in mortality became smaller for each increase in exercise. And that's because on a physiologic and outcomes-based basis, its benefits are substantial. It improves endothelial function, promotes angiogenesis, reduces inflammation, improves myocardial remodeling, greater insulin sensitivity. So all of these things are really powerful, and exercise is not something that should be forgotten. So wrapping it all up, we are now in a really exciting time. We can reduce risk with medications beyond statins safely to very low levels of LDL cholesterol with certain non-statin therapies. We can also reduce risk with EPA-only fish oil therapies. And then we can further reduce therapies directed towards insulin resistance in patients with obesity, not just to improve weight or glycemic control, but also to reduce cardiovascular events and mortality in doing so. But we have to also remember that implementing lifestyle changes in both primary and secondary prevention is our first therapy. So I'm the director of the MUST Lipid Center at Northwell. So I'm just going to put in a quick plug here. We offer guidance for patients questioning whether to just be on statins in general, to patients who need to be on multiple lipid-lowering therapies, or weight loss nutritional guidance, and we can offer services via telehealth as well. Thank you very much for the privilege to speak today. I'm available for any questions, queries, comments, concerns now or by email, and I left plenty of time for people to ask questions. So thanks very much again.
Excellent. Thanks, Dr. Hirsh. That was very informative and lots of great data for us to review. We'll open the floor for questions, either in the chat or if people want to unmute themselves. Looks like Elizabeth, I don't know who that is, just unmuted herself. Is that to ask a question? All right. I'll wait for some hand raising. So maybe I'll ask you this question just to sort of get us started. I mean, you talked about a lot of the newer agents that are out there, and there's obviously been this shift over the last 10 years or so from kind of treating to a target to sort of having people on medicines. And I think that's sort of shifting back a little bit. So when we see somebody, in general medicine in particular, take me through your thought process a little bit about how much are we looking at targets? How do we decide when to add Zetia versus really be pushing somebody for PCSK9 inhibitors versus referring somebody out to a lipid specialist? Like, sort of what are sort of the cut points or the key decision points in that process?
Yeah, that's a great question. So I think that kind of relates, back to that question about applying baseline risk to decision making. So I'm just going to quickly run back to that slide. Actually, really like this slide a lot, because it kind of, if there's any med students in the audience, it kind of helps illustrate relative risk versus absolute risk reduction. Let's see. Yeah, I'm not sure where it is. Anyway, the point is that basically the idea is to identify what their baseline risk is. So you do that through, obviously, if their family history to me is very important. Obviously, I like to start off. I like to start off with the ASCVD risk calculator, because it's a starting point in the conversation. And obviously it's not perfect by any means. It's very population based and there's a lot of flaws, but it's a good starting point in the conversation. Once we get there, I personally consider family history to be very important in cardiovascular risk kind of enhancement. And then obviously we have newer risk enhancing factors like preeclampsia, certain ethnicities, etc. And all of that comes together to develop that baseline risk. And then if you're still uncertain, or if the patient's just not convinced they want to take a statin or any other lipid lowering therapy, certainly a calcium score can come into play. And that's really powerful because it not only helps us identify what's actually going on in an individual patient versus an ASCVD risk calculator, which is a population base, but it's powerful for the patient because the patient really responds to a calcium score. Once they see that they actually are building plaque, it kind of changes their frame of mind. And they're using a lot of new technologies. Actually, there's a company called iTelligence where you can actually look through binoculars and look at the veins and arteries to try to stratify risk. So that idea of really determining the baseline risk to decision making is taking hold. Sorry about the long-winded answer to your question.
Oh, that was great. Thanks. What other questions are there out there?
Dr. Hirsh, thank you so much for your talk. I actually have a quick question about tirzepatide, which I know is a novel agent that many of us still don't know about. So just going back, have there been any studies looking particularly at tirzepatide and cardiovascular risk factors? So ongoing cardiovascular risk reduction. I know the study that you mentioned primarily looked at obesity and weight loss, but I think the patient population was not so much type 2 diabetics. So I was wondering what are some ongoing studies regarding the benefits of tirzepatide and reducing cardiovascular risk factors?
That's a really good question. Tirzepatide, the article just came out in the New England Journal, I think like 2 months ago. So it's very new. It is basically an augmentation of the effects of GLP-1 receptor agonists. So to answer your question, I don't think they've actually studied it for patients with heart disease. So I think that, if you're going to prescribe it for cardiovascular risk reduction, I wouldn't necessarily do that. I think it's more for prescribing it for patients who need really significant drops in weight. Although, honestly, when you get to 2 milligrams of semaglutide, you're kind of pretty close to tirzepatide. But the science is interesting. But to your point, I think the evidence is not there yet, and we should always kind of be skeptical, or at least caution is warranted, and using it for a variety of, or extrapolating its use to reduce risk and for a variety of causes.
Great, thank you so much.
Yeah, sure.
Dr. Berger has his hand up.
Yeah, I wanted to follow up, inspired by Manira's great question there. The lay press has taken on this cause of sort of the weight loss drugs and that they are sort of under-approved. To your point that you just said, they're not, the outcomes aren't as hard if you don't have all the, have not yet already developed all the other metabolic complications that go with a high weight. Could you speak to, because people I'm sure are going to be asking us all more questions, and it seems like you're on the vanguard of this sort of information. While you showed a lot of great things, that the downsides of these medicines in the in the studies they've done to kind of get them out there haven't really been seen. What are the potential things though that people should be thinking about before starting these weight loss drugs in conjunction with all the other therapies that that we are already using to manage the cholesterol and the diabetes and the high blood pressure and all the other things? What are sort of some of the smaller side effects, but things that we should all sort of know about that perhaps by reading the articles we don't fully appreciate it because we all have very limited experience with these medications as of now, other than I think people such as yourself who are really pushing the envelope.
So that's a great question. So I'll kind of answer that in two parts. So one, the smaller side effects, and two, kind of the larger implications. So I think with the smaller side effects, one is, that they cause nausea and vomiting because they slow gastric emptying. They can cause other GI related, diarrhea, etc. And you shouldn't be using them in patients with a history of medullary thyroid cancer. So these are just some of the kind of small things to be aware of. The bigger issue, and I still, I think about this a lot because I feel that I'm not sure. I feel that that's why I kind of brought up lifestyle at the end, is that, you're right. I mean, getting these medications approved is hard. And then, you have a lot of these a lot of these pharma companies that give you a year's worth of medication at a discount. And then what happens after a year? Well, I don't know. I mean, what I do know is that you're going to gain that weight back if you are relying purely on that, and you're going to gain that insulin resistance back. So I'm having trouble wrapping my head around it. Unless you have a patient that is, has Medicare or it has a stable insurance, how do you come off of these medications? So I think it's really responsible for them to undergo nutritional counseling. And I think that's the part for me that I struggle with is, am I prescribing these, responsibly? Because what happens, 5 years down the road or 3 years down the road when they come off these medications? So I think that remains to be answered. And I hope that kind of answered your question a little bit.
It really did. I think it sort of puts it in context of how we have to see them, not as a fix, but something that will still be a lifelong medication like all the other therapies, not something people can take time limited. And I think that's a great point that I hadn't really thought of and just changed how I think of them.
Great.
Right. Any other questions out there? Great. All right, Dr. Hirsh, I think you did it. I think you answered everybody's questions.
Well, again, a pleasure, and thanks for having me today.
Thanks so much for joining us, and happy birthday.
Thanks very much.
Thank you, Dr. Hirsh. Thank you, everyone.